Good afternoon, everyone. We are live today from Sakra World Hospital, Bangalore. We have with us a renowned gynecologist, Dr. Prabha Ramakrishna, who is the senior consultant and HOD and head of the Department of OBG and Gynecology at Sakra World Hospital. Yet again, we have another interesting topic, that is high risk pregnancy. So, without further ado, let's start the session. So, Doctor, you have been abroad, you have practiced abroad in Germany and UK. So, what makes Sakra special, or how do you rate Sakra when compared to where you come from or where you worked previously?
Yeah, see, the main thing which makes Sakra Hospital different from any other hospital, I would say across India, is this is the first Japanese, fully functional Japanese hospital in India. And I have been involved with the rest of my team from the inception, from the design concept stage, wherein we have got involved in putting in safety features in place as to how to design a safe delivery room and how to have a safe obstetric OT in place. And right from the design stage itself, we were involved, and that's where the collaboration between the management and clinician comes in, and it goes a great length to help to develop in safety for patients. The primary concern of any healthcare establishment is patient safety.
Yes.
And also the quality department was involved right from the initial start. The infection control team was involved from the start. So it's the whole the things which make Sakra stand apart is in the design stage itself. Starting from there to the operational issues, as well as the nursing team and the team concept between doctors. Like we work as one team. It's not like in many standalone units. It's all a consultant led. One consultant is in charge of only her patient, sort of a thing, which is very different here, where we work. The entire OBG department works as one team, and whoever is the best person to deal with a particular case is at the helm of affairs, and we pitch in for each other. And it's never a situation wherein a doctor is not available. And 24/7, 365, it is all of us get involved in the care of the patients, and that's what makes this stand apart to many other hospitals. And being a multi-specialty hospital has the biggest advantage because, see, pregnancy, all of us know it's a joyful event, and we do want the feel good factor and the niceties about childbirth. But we need to understand that maternal mortality is reality, even in the best of centers. Even in fully well-developed countries, they may have a lower maternal mortality than us, but still it's a reality, and it can strike anybody anytime. And it's not that somebody who has got labeled as, yes, somebody is at risk of having certain issues during pregnancy are not the only ones who land with problems. And anybody having a high risk pregnancy or a low risk pregnancy is a retrospective diagnosis. It's not that all pregnancies will land in smoothly, and it would be sad to got let down at the nth phase, where suddenly catastrophe strikes, and then people have to get shifted out in the middle of the night um, from smaller centers to centers which have facilities like in Sakra. And see, what usually happens in situations like that is the golden hour is past. So the biggest killer of mothers during childbirth is hemorrhage. And most standalone maternity units don't have their own blood banks. And in the middle of the night, people are asked to arrange blood from outside, and they run helter-skelter. And considering the demographics of cities like these, where people are nuclear families and they might have another small child at home and there's nobody else to look for help. These are people who would rather be safer in multi-specialty hospitals, where the doctors are working as a team. You may be alone as a family, but Sakra family is around for you.
Yes, absolutely. So, Doctor, here are a few questions from our viewers. So, one of them is, at what age does the pregnancy become high risk?
Well, there's no particular age where we can say, okay, you turn X number of years today, so from tomorrow you're high risk. Technically, in obstetric textbooks, it's labeled as 35 years and more. But it's not that the next day you suddenly become high risk and you were not that before. As I told earlier, it's a retrospectively. I would come the other way around. What can we label as a low risk pregnancy? See, we can say somebody has had a low risk pregnancy if pregnancy has gone on fine completely, she has had an absolutely uneventful childbirth, and then baby goes home safe, her mother goes home safe. That's what is a low risk pregnancy.
Yes.
But that is something when it's all done.
Yes.
And till from the time the mother conceives to she taking her baby home, she going alive, baby going alive happily is something we all look forward to. And it's only a retrospective thing that say yes, she had a low risk pregnancy, because in all these cases something can go wrong.
Yes. And at what, why is there a sudden rise in high risk pregnancy nowadays?
Yes, one of the factors is the lifestyle. The demographics have changed, the age at conception has changed, and because of less physical activity and the diet that people are having these days, there's very high rise in the obesity indices and the medical disorders like blood pressure, diabetes, hypothyroidism, all these are on the rise. And with increasing age of the mother, there are also other gynecological problems which add on, like their ovarian reserve becoming less, high chances of they being infertile, they needing additional reproductive technology like IVF and things like that, which will again push them towards being more and more anxious about the whole pregnancy, and that leading on to develop further medical complications. And with increasing age, we see fibroids developing in women, and endometriosis in women, ovarian cysts in women. So all these are things which add on with increasing age.
Yes. So does stress also play an important part when it comes to high risk pregnancy?
Yes, it does, because see, when we say stress alone may not lead to any particular, we cannot label say stress caused the pregnancy to go bad.
No.
But stress definitely changes the other medical conditions which can come in, like gestational diabetes, like blood pressure in pregnancy, and many other medical issues which, see, in the previous generation, blood pressure and diabetes was something people used to get in their 50s or 60s.
Yes.
And nowadays we see younger girls in their 20s and 30s starting to have these problems. And there's a huge population of women who are pre-diabetic. They just go unnoticed and they don't even know that they are having this problem. And they are the people, the pre-diabetic are the one who will develop gestational diabetes in pregnancy.
Then what are the factors which contribute to high risk pregnancy?
Yes, like what I already mentioned in terms of maternal age, having other medical disorders.
Yes.
Some would know about their medical disorders, like having epilepsy, having heart problems. Either we do see quite a number of women having heart valve replaced and having epilepsy and having other neurological conditions and having diabetes, hypothyroid, all these conditions.
One more interesting question is, what are chromosomal problems and what causes such problems?
So chromosomes are our building blocks. All of us are made up
Yes.
of chromosomes, and human beings are made of 23 pairs. 23 pairs, and women are made of 2X and males are made up of 2Y, X and Y. And in these 23 chromosomes, what happens during the baby, the formation of the baby is half of mother's chromosomes and half of father's chromosomes come together to make a baby. So in the process of division of the cell and reunion and formation of the new cell, which is the embryo, there can be certain additions or deletions or mismatch happening, which can cause the chromosome abnormalities. So there can be an extra chromosome, there can be one chromosome which is less. You would have heard of conditions like Down syndrome.
Yes.
So Down syndrome is typically a trisomy 21, which basically means there's a defect in the number 21 chromosome. So like that, there's Edwards syndrome, there's Patel syndrome. They're common chromosome-related abnormalities. But some of these, like the Down syndrome specifically, has something to do with maternal age. To give an example, has a sort of a thumb rule. So if a woman in her 20s, what is her risk of having chromosome 21 Down syndrome risk? Today, something like 1 in 2,500.
Yes.
So when she comes to around 35 years of age, it comes to like 1 in 250. At the age of 40 years, she has a risk of 1 in 40. You can see the exponential rise with increasing maternal age. So we do appreciate the fact that these days, for career reasons, women are pushing forward the age where they would plan to have babies. And this is something they need to keep in mind, that yes, our demographics have changed, our lifestyles have changed, but unfortunately our biology has not changed.
Yes.
And yes, we do go through the aging process, and specifically to do with women, because women are born with a set number of eggs.
Yes.
And as the age advances, we are dealing with older and older eggs. And when older eggs undergo a conception, the chances of defects in them become more. So we do have women who are more than 40 years of age having their first babies also. But yes, we have to categorize them as high-risk pregnancy and do whatever extra tests are needed specifically to look for these chromosome-related abnormalities. And that's where a dedicated fetal medicine unit comes in. So we have our own fetal medicine unit in association with Bangalore Fetal Medicine Center. And they're doing a wonderful job in identifying who are at risk of identifying chromosome-related abnormalities and what can be done about that. Because these are not treatable conditions. They're something which the children are born with. And it would be very hard on the parents to not get diagnosed with conditions like Down syndrome, where children can be born with major deformities and mental retardation. And we don't have a support system in here like in many countries in the West, where there are patient support systems and caregivers are there to deal with difficult children like this. But we don't have those things, and it's like the financial expense also are needing to be borne by the parents.
So as you said before, ma'am, what is fetal monitoring and when is it used?
Fetal monitoring is by and large, you can categorize as in pregnancy, in labor, it can be in various forms. So we start with the first heartbeat that we listen to of the baby, and that's usually by an ultrasound around 7 weeks of gestation. And further on, we monitor for chromosome abnormalities, as I told you, in terms of doing an ultrasound called an MT scan, and some blood markers for hormones in pregnancy. That's called the first trimester screening. So that's done around the 12 weeks. And then the next set of tests comes in where we do either the quadruple marker and anomaly scan, which we do in the second trimester. And further on, how many scans we do or how frequently we do is very individually dependent on the patient features. If the mother is having risk of baby having been very small, or the baby becoming very big, like you would know that diabetic mothers have big babies, and people who have blood pressure, they tend to have smaller baby because of growth restriction happening in the baby. So there's a wide report, but there can be many subcategories in that. And when we talk of further monitoring, it would be monitoring the growth of the baby. That again would be by taking ultrasound parameters of how the baby's tummy circumference is, what's the length of its thigh bone, what's the circumference of the baby's head, how is the water around baby, and how is the blood flow to the baby. This is all seen by our fetal medicine doctors. So once they come in labor, when we talk about during delivery, around the time of delivery, the entire length of labor, which could in a first time mom could be 8 to 10 hours. So the babies need to be monitored, because when we talk about labor, what we are dealing with is there's a passenger, which is the baby, the passage, which is the mother's pelvis, and the journey of the passenger to the world.
Yes.
From where it is inside. So we need to ensure that what we cannot change at all is the passage. It's a fixed. Mother's body is fixed, and what we can need to monitor is whether the journey is smooth for the baby, whether this passenger is making the journey smoothly. So this entire length of labor we would be monitoring using a cardiotocograph, wherein we are monitoring the contractions of the uterus as to how hard the contraction is pushing the baby down, and we'll be monitoring the baby's heartbeat to know whether it is getting stressed out inside. So in the process of labor, if baby is getting stressed out, to ensure safe delivery of the baby, we might have to resort to a cesarean section.
Then how does BP or sugar level contribute to high risk pregnancy?
See, blood pressure and sugar levels, there are two categories of that. One is something which the woman already knows she has that, like chronic hypertension, or she's already having type 1 or type 2 diabetes. The other one is the ones which develop in pregnancy, which is called gestational diabetes or pregnancy-induced hypertension. Okay. So this can be a huge spectrum. Like, for example, if we talk only about the blood pressure part right now. So chronic hypertension is because baby, the mother is already having high blood pressure. She might be on certain medications to control her blood pressure. Some of these cannot be continued in pregnancy. So as soon as we know that the mother is having hypertension, we'll have to ensure that she changes over to the medicine which is safe for baby and keeps her blood pressure in control throughout pregnancy. So compliance is a big issue there because many people suddenly stop and they don't report to the doctor that yes, they've got pregnant, and so these sort of problems can happen. So it's important that anybody who's having any medical disorder, they need to go for a preconception. Because if you ask me which is the most important checkup a woman should have regarding pregnancy, I would say it's the preconception one. Because it is like, very simply put, you're planning a journey with your vehicle for 9 months. Wouldn't you take your vehicle for servicing and getting checked by your mechanic? So you need to get your body checked to know whether your body is in a fit condition to take the journey of motherhood. So we need to, that's the best time to identify problems and optimize the medical condition so that the journey for the mother and the baby is smooth. Yes. There's a very, in ancient feeling among Indians that childbirth is like rebirth for the mother. Yes. I would say it's really true. Because so many times mothers do lose life. And they're precious life because they're young ladies, young women who are otherwise fit and well. And the pregnancy should not push them into death. And there's so many, majority of maternal mortality is something which can be prevented if handled with proper personnel in proper places.
And obviously with proper hygiene.
Yes, it becomes very important. And so if you talk of, in lower socioeconomic sector, yes, it could be related to hygiene, as you said, or it could be the increased chance of infection. But across the world, I would say at least in the majority of the world, the leading killer is bleeding during delivery. The next is high blood pressure in delivery, around the time of delivery. This is severe preeclampsia and hemorrhage. These are the two major killers for mothers during childbirth. So if these are handled, it's like, majority of death during delivery of women can be prevented.
Then one more question is that can taking birth control pills result in high-risk pregnancy?
Well, birth control pills obviously would not be taken when she is pregnant, yes, and she would have taken it before. And the effect lasts only as long as she has been taking it. So it would have no complications during pregnancy or childbirth.
Then does a man's age affect high-risk pregnancy when they try to conceive?
Not particularly, though there have been some studies which show that the advanced age of the father could be associated with the psychological development of the baby and behavioral abnormalities in children, but structural abnormalities are not something which are associated with paternal age.
During pregnancy, what is the right duration of time that a woman can actually pursue her career, work?
Well, personally, I took only 4 days leave during my first child. I would say that it's important to keep yourself active, and if there's been no medical complication which necessitates that she has to take bed rest, which could be, I would say, less than 5 to 10% of pregnant women, most of them would be able to continue their career. But again, the main determinant, at least in centers like urban centers, is the difficulty in commute, the distance that's taken, the traffic, and things which are not medical really. And yes, work-related stresses. So If that is something you are enjoying what you are doing, then I don't think there should be any problem with that.
And what are the lifestyle changes we need to adopt in order to lower the risk of pregnancy?
Main thing, yes, it goes back to basics, like what we love. What we would all learn in primary school: eat healthy, exercise adequately, drink adequate water, eat on time, sleep on time, be happy. Very simply put, it's just that. But yes, as I said, stress does add up to many other medical problems, and like what I already mentioned, optimizing if there is a medical problem. We do see people when they come for their generally majority of people still come after they know that they are pregnant. The damage is already done if she has a medical problem which is way beyond her control. The reason is, if we talk of, say, diabetes, for example, if her average HbA1c has been something like 8 or 9, which is the average 3-month blood sugar value, then she has already done damage to the conception, at the conception stage itself, to the baby. And there's no going back on that. Whatever control she does beyond that, it's not going to make it any better. So we would tell them, if we know that they are already having diabetes, our endocrinologist does meet up with them and advise them to control the sugar levels and bring it to a level where it is considered safe. For example, HbA1c, which is normal for pregnancy, is something like 5.6.
Yes.
But in people who are already diabetic, it's impossible to achieve that. But what is reasonable? Something like less than 7 HbA1c is what we aim to get before she even tries to get pregnant.
Thank you, Dr. Prabha. That was an interesting insight on high-risk pregnancy. So for those who have any questions or queries, please drop in your questions in the comment section. We'll get back to you shortly with the answers. Thank you.
Thank you.